Dr. Ramamurthy sir to share his screen and start his presentation.
Thank you, Dr. Gaurav, for having me in this course. The topic given to me was dealing with an unhappy smile and Lasik patient. I dropped Lasik. When I saw Gaurav's presentation, I thought, oops, what am I doing? But then I thought it will be a repetition. But fortunately, he dealt with intraoperative complications. I'm going to be dealing with the post-operative unhappy patients. So possibly this will sync well with his presentation. What about residual error power enhancement after smile? Whenever there's a residual error, for a long time before the Circle software became available to us, and especially now that it's being offered at no price, certain numbers, now we do more of Circle. But then when it was not available, we used to do simple PRK, where using the streamlight, go ahead and remove the epithelium and subsequently take care of whatever residual aberration is there, residual error is there. And this used to work very well. It was essentially like the PRK procedure enhancement after a flap procedure also. Invariably, in all these cases, we use mitomycin C for 30 seconds, and the results were quite satisfying. Now, of course, the Circle software has become available. Obviously, when we used to do PRK for a day's time, the patient used to complain of irritation, discomfort, watering, prolonged usage of steroids, etc. Here, we are able to convert the cap of the smile into a flap and lift it up. Basically, there are certain parameters that you feed in, and then subsequently you can see that this is the cap being converted into a flap, and we can lift up the flap. The thickness of the flap is same as the cap, and whatever error is there, then you can go ahead and treat this. The arguments I have against the very simple procedure, very easy to do, and the results are also very satisfying. But what I have against it is that, all along you have been promising the patient a flapless procedure, and now you are making a flap with all the vagaries of the flap. And the other thing is, when you're doing it in the smile, if you're doing a PRK, it is basically only the stroma in the cap itself that you're using. The underneath stroma thickness is not used. But in this case, you are lifting up the flap and subsequently using up a little bit of the stroma, and maybe this has a propensity to biomechanically weaken the cornea more than a PRK procedure on the cornea. There's no scientific evidence for what I'm saying, but this just sounds logical to me. But having said that, now because the Circle software is available, more often we use that. Retained lenticule segment, Gaurav very nicely showed what he does on the table when he has a problem. But in case the patient has come post-operatively, therefore this was a very simple case of minus 1.5 diopter spherical error in both eyes. The girl underwent treatment in both eyes, and basically one of my associates had done that, and he did realize that he had left behind the lenticulus were not completely removed. So he removed one part of the went inside and removed what he thought was the balance of the lenticule. But on the first post-operative day, this was the refractive error. You can see -2 with a -3.5, and a very typical bow tie over here. The lady was absolutely mad because she came with a 1.5 power, and this is what we ended up with. And we thought this will be a retained lenticule. I had a look at the video of the primary surgery, and subsequently this is what we decided to. This was on the first post-operative day itself. We thought there must be a lenticule remnant in the center. Because it was not getting delineated, injected some triamcinolone acetate, and that really showed up the lenticule very clearly. As you can see, this is essentially the lenticule which is right in the pupillary area, and we had to, this was stuck onto the back of the cap as it usually does, and we had to peel it off that. And you can see basically what had happened was the surgeon had taken off one half of the lenticule, then thought he had taken off the second half, which was the inferior hemisphere, but in between there was a strip of lenticule that was left behind, which was causing the problem. So we had to go in again on the first post-operative day, remove it, and very gratifying results, maybe because the steroids also that went in, that there was a plano refraction with a 6/9 visual acuity on the first post-operative day. Most importantly, the vertical bow tie, that the oblique bow tie that you saw in the earlier picture, it completely disappeared. and even this settled down over time as we followed up with serial topography. Retained lenticule 2 months post-op from a patient who had been done elsewhere. Basically, this is the history that was available to us, where a simple 2.753 diopters had been corrected. The left eye, the procedure was uneven full, and the vision was 6/6. In the right eye, the uncorrected visual acuity was 636, and even the best corrected visual acuity was only 6/18. And there was a very irregular refraction. The patient was not really referred to us, but then came to us looking for a solution. So we did not have complete access to the data or the surgical video. Whenever you have a retained lenticule suspected, it's always a good idea to review the primary surgery video carefully, and most often it will show up as to what went wrong. But when we correlated the findings, what you can see over here is that the patient has 45 point, very steep cornea on the temporal aspect, while on the nasal aspect is flat cornea, which gave us an idea that maybe there was a piece of lenticule left over here. And also when we looked at the corneal thickness, the pachymetry, you can see again there was a significant difference in the pachymetry, 491 and 542, and obviously there was something left over in this quadrant. And again the AIOC2026 picture again showed us there was possibly a lenticule fragment here, quite clearly delineated. And most importantly, just in case you don't have access to these things, just a dilatation and a simple slit lamp examination shows in retroillumination that you have a clear cornea here, while in the area where there is a residual lenticule, there is a very rugose picture that is seen because of the disturbance in the corneal texture. So essentially we just went back again, did not have to use triamcinolone because here we knew exactly where to look for the lenticule, and that's essentially, this is being opened up almost 2 months after the primary surgery, and that's the lenticule that's being taken out. And can it take a couple of minutes? That's the lenticule that's taken out, and immediately the patient's problem settled down. This was what we saw prior to the surgery being done, and once the surgery was done, you can see the cornea is flattened out quite uniformly and obviously with good results. Iatrogenic ectasia post-smile is extremely rare, and but here is a patient which is quite a significant error that we have treated bilaterally, one eye minus 8.525 with 2.25, absolutely pristine cornea, and both in the right eye and the left eye. The power treated in the left eye was quite significantly less, and both the corneas were quite good. Nowadays, when it comes to -7, -8 diopters, I would rather think of a phakic intraocular lens because the quality of vision it offers also. But this was done almost some 8 years back, and 4 years this patient was living in the UAE, and he went away. 4 years later, he came back with -6 diopters and -4 diopters in the right eye. And you can see there was a full-blown iatrogenic keratosis over there. Fortunately for us, left eye was doing still very well with a plano refractive error and a 6/6 visual acuity. We went ahead and did a intact procedure for him. I'm going to skip the video, and did a cross-linking also along with that. And this is what we found, where not only the error came down, but most importantly, the best corrected visual acuity improved to 6/6. It's a more centered cone we have now, and the fact that it was improving with the refractive correction gave us the confidence. And 1 year after the surgery, you can see the follow-up. This was immediately after the intact, 6 weeks later. This was 1 year after that. Once we knew that the difference map showed there are no further topographic worsening and the refractive error also remained stable, we went ahead and implanted a toric phakic intraocular lens. So this is a patient who came for smile surgery, developed keratosis in one eye, then subsequently we had to do topo-guided PRK with CXL, and finally a year later we could rehabilitate him quite completely with a phakic intraocular lens appropriately placed. And this is what, and the surprising aspect is, even though the left eye had a slightly lesser refractive error, right through the 10-year follow-up, the left eye remained pristine and nothing really affected it. So both the eyes had undergone the same procedure in the same center. And post-smile epithelial ingrowth, just to show you, sometimes you have this problem, and very rarely so. And here what we do is to just go ahead and access that area, scrape it off, and then put some 20% alcohol over there. That's what is needed, and not the mitomycin C, because you want to kill the epithelial cells over there. And once we did that procedure, then this is basically that epithelial ingrowth being debrided off, and then subsequently washed with a diluted 20% alcohol. And one day post debridement, this was the picture, and you can see that is gone. And 6 weeks later, this was hardly seen. DLK post smile is also possible. I'm going to close off this. Handling is something similar to what you do. This is just an incidental post-op day 1 epithelial defect. Obviously, patient came with a lot of irritation and discomfort. Placed a BCL for 3 days, and this sort of subsided. And apart from this, of course, post-operatively, we face the complications of dry eye, infectious keratitis, TLSS, etc., which has to be dealt with appropriately. Thank you so much for your kind attention.
Thanks, Dr. Ramamurthy sir, for those very nice videos. One quick question before Dr. Chitra takes over. Like, how common, because you do very high volume lenticule extraction in various platforms, how often have you seen epithelial ingrowth? Because compared to your Lasik practice, isn't it like almost...
This is only one of 2 cases.
Right. And what do you think maybe the reason when it does happen?
I think
what might be the etiology?
It's possible that there is some amount of epithelial cells which are dislodged at the site of the incision, and when you're going in to dissect out, maybe you're taking in some epithelial cells, and that's why. And because the incision size itself is very small, maybe that's one of the reasons that the ingress of epithelial cells is less here compared to a conventional flap surgery.
Absolutely. So, do you practice washing the interface at the end of surgery? Because some people like to do the wash. Some people say that we don't want to do the wash. I'm just wondering whether that has a kind of,
we were washing initially. Then in between we stopped washing. Then when we started doing clear, then they suggested wash it, because initially the results were not that great and we had to iron out the wrinkles. Now I have started doing it routinely. Actually, I do what you do, in the sense that what you have suggested, in the sense the hydro expression of the lenticule. So once it's separated, I just don't go in with a spatula, but go in with a flush of fluid. That sort of brings out much of the lenticule outside. And that takes care of the wash as well as brings out the lenticule, and then they just iron out the
I hope you're using my cannula. Have you bought my cannula for the hydro?
Have any financial interest?
Finish this session
no
fast.
Financial interest.
The next session you have to come to you too.
Okay.
Both of you.
Yeah.
Do not wash.
I don't
Lasik?
wash.
It's not for that, Sonu. I think it's not for that. Basically, when you go in with the dissector and you are going in from the epithelial, the cut, and there is always that small possibility that you are implanting some epithelial cells into the interface, right? Because you're going in and coming out a couple of times with your manipulator, and if you have left something inside, it's just a good idea to have it flushed out. So what I typically do is I go in from the side, push one gush of fluid just near. I go obliquely into the pocket from one side. I put a small gush, it just goes around and it comes out just about like 0.2, 0.3 ml or maybe 0.5 ml is all that is required, but it leaves the interface clean.
It's not only for washing the interface, it's also for ironing out the micro wrinkles that may form in the Broman's layer. So once you're pushing in some fluid, there's a certain amount of hydration of the cap that happens. And definitely after the surgery is over, I do a few times I iron over the cap, and I think that sort of smoothens up. It's all, both when I was washing, not washing, I cannot say the results were much different.
Exactly.
So I think for the ironing, he recommends that you use a Merrill's sponge and then iron it out, and then he takes the patient immediately post-op on the slit lamp, stain with fluorescent dye, see the microstriae, and then he also irons it on the slit lamp. So that's the way they take care for the microstriae, immediate post-op, taking the patient on the slit lamp and then staining it. But I think fluid doesn't, it's just the mindset. I think fluid doesn't take care of the microstriae at the Bowman's level. So it is the Merrill's sponge and then...
I think what works best in your hands is what is good for
yes,
you.
yes.
Right. So I'll invite Dr. Thanks, Ramamurthy sir.